Bismillah ar-Rahman ar-Rahim. This is a basic overview of spinal disorders and back pain in Rheumatology, Orthopedics, and Sports Step 1 program. We have 4 questions to discuss. 54-year-old man comes to the office due to aching pain in his left neck and shoulder area for the past several months. He has also numbness and weakness in his left hand. Examination shows decreased sensation in the palm and index and middle fingers, along with weakness of the left elbow extension. Triceps reflex is diminished. The question is, a lesion affecting which of the following labeled sections of the brachial plexus is the most likely cause of this patient neurological findings? In the figure of the brachial plexus, we see 5 roots, trunks, divisions, cords, and terminal branches. You could see that C7 contribute importantly to the development of median and radial nerves. In this patient who developed radiculopathy, cervical radiculopathy, indicated by the aching pain and shoulder pain, C7 is the most commonly affected. So C7 root of the brachial plexus is the most frequently affected in cervical radiculopathy. And the deficit, as we saw in this patient, developed across the medial and radial nerve distribution. That's why he developed triceps reflex diminish, elbow extension weakness, and sensation, lack of sensation or decreased sensation in the palm, index, and middle finger. 14-year-old previously healthy girl is evaluated for a 3-month history of low back pain. She is a member of her school gymnastics team, and the pain is worse after training sessions. Physical examination shows tenderness in the L5 region. Spine X-ray reveals anterior displacement of L5 vertebra relative to the S1 vertebra. This patient condition is most likely caused by injury to which of the following structure? This is a condition called Spondylolisthesis, in which there is fracture and bilateral fracture of pars interarticularis. With a fracture of this part of the vertebra, there will be anterior displacement of the vertebral body, and that causes the symptoms. So in spondylolisthesis, there is anterior displacement of vertebral body. It results from bilateral fracture of pars interarticularis called spondylolisthesis, and risk of this condition increase if there is repetitive extension of the spine, similar to our patient here who is a member of her school gymnastics, because that creates stress on the facet joints and posterior vertebral arch, resulting in the fracture and development of this condition, spondylolisthesis. 72-year-old man comes to the primary care clinic with 6 months history of back and bilateral thigh pain provoked by walking. He normally can walk only 2 to 3 blocks before having to stop due to pain. However, when he's out walking with his grandchild, leaning on the stroller seems to provide pain relief. Occasional tingling sensation in his lower extremities. I want to highlight to you important thing in this scenario, because when there is a leg development, when the patient is walking, this is called claudication. And we need to differentiate between vascular claudication and neurological claudication. In this scenario, we see the patient that leaning on the stroller seems to provide pain relief. And this is a feature of neurological claudication, not a vascular claudication. The vascular claudication is due to occlusion of the arterial system to the lower limb, and that results in ischemia with walking. But with neurological claudication, there is spinal stenosis. There is spinal stenosis that results in the pain development and decreased sensation. The question here is that thickening of which of the following ligaments is most likely contributing to the patient's current condition? The answer is ligamentum flavum. Ligamentum flavum, as we see in the figure, is located here. This is a normal vertebra. We have the intervertebral disc, and we have the spinous process out here, and now we have the ligamentum flavum. Hypertrophy of this ligament results in compression and stenosis in the central canal, thickening of ligamentum flavum, hypertrophy of the facet with the development of osteophytes that all happen with aging, resulting in this feature. So aging causes degeneration of the intervertebral disc with protrusion, and that increases the load on the posterior spinal cord, which is posterior to the intervertebral compression on the posterior. And look at the ligamentum flavum here, how it is hypertrophied compared to the normal. Osteophytes, ligamentum flavum hypertrophy, and that all results in compression of the nerve roots, development of lumbar spinal stenosis, neurological claudication, and the patient develop back, thigh pain, which is, as we see in the question, relieved by leaning forward. 76-year-old man comes to the office with 2 months history of progressive low back pain. The pain is relatively constant and nagging and is unrelieved by rest or position changes. It is especially bad at night and interferes with sleep. Medical history is significant for hypertension and osteoarthritis affecting the knees and hands. Question is, which of the following processes is most likely responsible for this patient back pain? Back pain is a common symptom, especially in elderly. But the question wants us to know the red flags of cancer. This back pain in this patient is most likely neoplastic, and we need to suspect that if there is a red flag. So look at the note here. Back pain from underlying neoplasm should be suspected. If elderly, okay, that's fine. But look now, constant and not decrease with position changes or analgesia, and also worse at night. All these are present in this patient. So it is worse at night, interfering with the sleep. Sometimes it might tell you it awake the patient from sleep. So these are features that are red flag, require further investigation for cancer. Also look at the note. If there is a history of cancer, for example, prostate cancer, if there is weight loss, point tenderness on examination, or development of weakness. Of course, prostate, breast, lung, kidney, thyroid tumors are most common primary tumors that metastasize to the vertebra.